Hey, this is Dr. Livingston, and here is our lecture on suicide and suicidal ideation assessment. So let's look at some numbers of suicide risk. So I've got a bunch of percentages there, and I'm not really going to read those off to you, but I do think that it is important to recognize that those 40 to 80% of adolescent suicide attempts were clinically depressed, meaning that they would meet criteria for major depressive disorder. Um, 33% of those will go on to, as terrible as it sounds, be successful in completing their suicide. Um, so we just have to understand that, if someone has a previous attempt, that does 100% put them at a higher risk of following through and completing a suicide if they were to try it again. Now, adolescents with mood disorders, 12 times more likely to commit suicide. That means when we say commit suicide, that means actually complete. Um, and the disorders that place people at the highest risk, and this is for adults and kids alike, is going to be major depression or a bipolar disorder, along with a substance use disorder of some sort. Um, Outside of that combination, then we also have to look at borderline personality, histrionic, and narcissistic personality disorders that place that group or people within that group at a 4 times higher risk for experiencing suicidal ideation and then also having suicidal behaviors. And when we say suicidal behaviors, that means um, doing things that appear as if they are planning or attempting or planning to attempt uh, suicide. So hopefully none of this information is completely foreign to you guys. I know that you've looked at leading causes of death before in other courses in nursing. So let's look at how suicide rates within those. So for age 10 to 24, which accounts for 15% of all suicides, it is the second leading cause of death, following behind accidents. So that's something that we really need to be aware of because that's a very concerning number. Um, Within that age group, out of 100,000 ER visits, we have 354.4 of those visits are this age group. Um, Now that's the average. Um, if we look at gender differences, and this is in minors still, we see that the from 2020 to 2021, um, that number actually doubled for girls and females. Um, so that says a lot about there's something happening out there that that we need to be a little bit more aware of and really paying attention. Um, An interesting thing, though, and you might have heard this before, is that even though women are more likely to attempt suicide, men are actually more likely to be successful at completing suicide. And the reason for that is because men tend to choose more violent methods. Um, that it's hard not to be successful. Um, so just something to keep in mind with our male patients. Um, Now, here's some numbers of the more specific vulnerable populations within our mental health vulnerable population. Some of this data is coming from the Youth Risk Behavior Surveillance Survey, um, and others are coming from CDC and Healthy People and that. Now, there are a couple of these that I want to point out. Um, in the LGBTQ plus population, we've got 58.5% students within that population have attempted at least once in the past 12 months. Um, and that does continue to increase. Variety of reasons for that I won't get into. Now, Healthy People 2030, they have actually identified within that report that suicide risk can be decreased by 50 to up to 75% with just one supportive adult. That's important because sometimes we as site providers might be that one supportive adult. So just being aware of that. Second one I want to point out is over here with schizophrenia. Now, very low rates ish. Um, they make up only 10.1% of all suicides. 5% of patients with schizophrenia will actually die by suicide. However, the number I want you to really pay attention to is that 50% have attempted or at least experienced suicidal ideation. And remember when we were talking about schizophrenia, um, and we will, of course, talk about that one again. There's a lot that goes into the psychological adjustment that people have to go through when they have a diagnosis like schizophrenia. So it's not necessarily surprising to see that we have that high number of attempts and or uh, experience suicidal ideation within that population. And again, we'll talk way more about that when we talk about schizophrenia this semester. The last one that I want you to see is, or to point out rather, is at the very bottom, borderline personality disorder. So if you look, there's a huge difference between the number who will attempt, 70%, and the number that will actually die by suicide, and that's only 10%. Now, what this tells us is that even though our patients with borderline personality disorder might have frequent attempts, um, we still have a good population of them that will actually be successful with that. So there there are times within the mental health field that we see other providers that might be like, oh, they're just trying to get attention, or yeah, that's what they do, and they don't get their way, those types of things. But we have to remember that there's still a pretty hefty chance that they will actually have a successful attempt. And so for that reason, we do have to take every single report of ideation and attempts very seriously. In this slide, I'm not going to read through all of these. This is a big long list. But what I've given you here is for the most part, all of the recognized contributing risk factors to suicide. This is not a comprehensive list by any means at all, but this is some of the big ones, and pretty much as many as I could fit on this slide. So, a couple of ones that I want to point out here. At the top, we've got previous suicide attempt. I cannot say or stress enough how much that um, is a primary risk factor. It's probably, or actually is, the biggest risk factor um, to a completed suicide. Um, Jumping around here, down at the bottom of that column, we've got a sense of hopelessness. Now, of course, hopelessness is always something that um, we want to assess when we're assessing suicide, but um, there are a lot of people that don't recognize the high level of risk that's associated with our patients that just don't see how anything could ever get any better. Um, then on top of that, we've got that stigma that's associated with help seeking, and especially with mental illness. So a lot of people are very hesitant to even talk about how they feel, um, so that they can get help. On the next column, bullying. Now this is one that there's a lot I could say. I'll just leave it there. But it is also one that a lot of parents and school officials and school administration rather don't really recognize as it being as serious as it actually is. Many of the people that are in educational administration, principals at school, stuff like that, um, they are, and I'm going to somewhat blame generations, but they are typically from a generation where, and myself included, where, bullying was kind of normal. It was normal to see that happening. And there was never really the big association with how much that can affect someone's mental health and their own uh, self-esteem and self-image. So the reason that I bring that up is because a lot of times, you guys that are going to end up working with kids, or anybody that is working with kids, um, we need to take those reports of bullying seriously and actually even ask the kids that we work with if they're being bullied and give them some examples. Um, because there is a big stigma attached to bullying at school as well. Because a lot of people, I just the other day had a conversation with a little girl that is 100% being bullied, and said that she doesn't want to snitch. And so that's a very challenging um, perspective to deal with, because it's certainly not snitching if it's actually causing you harm. Um, so there's a lot that goes into that. And then the final thing is discrimination. Um, and that's something that we also don't really think about a whole lot of how being discriminated against in a variety of different aspects of life can put someone in a mental headspace that they experience that sense of hopelessness and don't see how they can get ahead at life, and all of these sort of things. And of course discrimination can come in a variety of different forms, and isn't just racial. We can have gender discrimination, age discrimination, um, people who have past legal charges, they get discriminated. So there's a lot of different areas, um, but it is something that we also need to keep in mind. So now these are the specific risk factors. So again, I'm not going to read off this list, but just kind of going to point out some things, give you some extra information here. So like I was saying before, having a previous attempt is definitely the most predictive determinant of risk. So if we do have someone that is um, currently experiencing suicidal ideation and they do have a previous attempt, doesn't matter the lethality of it, um, that is going to be the biggest way that we can predict how high of a risk they are actually at. Um, Depression, of course, that also increases our risk. It's not necessarily a predictive factor, but it does significantly increase risk because 15% of people with depression um, will either experience suicidal ideation or have a suicide attempt. Now, let's talk about the short-term risk factors briefly. So these are kind of the acute risk factors that are more likely to be present within 1 year of suicide, so like the year prior. Um, but we can actually modify these, so we can improve these. We can decrease the risk of suicide by addressing these short-term risk factors. So, um, as an example, insomnia. Well, we can treat insomnia, and having that treated um, is going to significantly reduce the risk of suicide, and it's something we can do something about. So all of these in that column are ones that we want to assess for and make sure that we're treating those appropriately and adequately so that we can decrease that risk. This one is our risk factors that are specific to children and adolescents. So over on the left-hand side, those are ones that pretty much go throughout all of, you know, birth to 18 years old. Any of those are going to increase our risk. Adverse childhood, no, adverse childhood events, I wrote that backwards, um, are something that we're going to review in more detail in a future lecture. So we'll come back to that one. On the right-hand side, these are ones that are more associated with our adolescent population, um, but we could certainly see these things occurring younger and younger in recent years. So now living alone, we do have some teenagers that do live alone, so or essentially live alone. Um, and now let's talk about things that are a little bit more on the positive side there of suicide, if there can be one. So we always are going to have preventive and protective factors. Well, our preventive factors are, for the most part, these listed here. Um, the only one that I really want to point out, because remember, our preventative factors, these are things that we can kind of help, we can change. These are modifiable. So having reasons to live. This is the one that I really want to talk about. Um, because this can be something that is as simple as just having plans for the future, um, having a long-term life goal that they can look forward to, that they have a reason to live. Other ones that we don't always think about that are very much so preventative factors um, are going to be a fear of social disapproval. And that one is kind of an interesting one because it actually uh, will prevent someone from engaging in suicidal behavior or making an attempt because they because they don't want to be viewed negatively in the community. Um, and then along with that would be moral objections to suicide. Now, protective factors. So here's our list of protective factors. And again, you see that having reasons for living. So that one is one that is definitely a preventative and protective factor. Some of these other ones are ones that we can also assist with to increase the protectiveness within our patients by getting them connected socially, making sure that they have strong support systems, um, feeling like they are part of something is very important, and it is definitely protective against um, suicidal ideation, and suicide attempts. Um, one of the other ones is effective coping and problem solving skills. So again, this is something that people can learn, and we can help with that. Let's talk about those predictive and protective factors specifically in children and adolescents. So for the predictive factors here, and again, predictive meaning it's going to predict if we're at high risk or, if it's going to happen. That lack of future planning, um, making suicidal statements, we do have to take these seriously, but kids now do say these types of things a lot, and it tends to be just a dramatic theatrical flair. Um, but at the same time, we don't want to take those statements lightly, so we do want to ask more questions if those types of statements are being made. But the big one that I want to point out is that suddenly becoming cheerful after a period of depression. Now, children and adolescents are labile in their moods anyway. That's kind of the nature of being a teenager, and children also, just that flippant nature of their moods. However, this is where we have someone that there's a distinct period of depression, and then all of a sudden they're fine. That is something that is concerning because we want to make sure that these folks are not um, pretending, if you will, to be fine so that no one is really watching them for the possibility there. So that actually is a big one that we also don't really think about. So anytime we see a child or adolescent aged person that engages in or exhibits that type of behavior, we want to definitely keep our eye out. That doesn't mean we're in the clear yet, or they're in the clear yet, rather. Now, our protective factors, not surprising, obviously, um, but some of the other protective factors can be obviously absence of depression, um, not having any substance use history, not having any history of physical or sexual abuse, not having access to firearms, not having a family history of suicide also. So those are also protective factors, but I didn't feel like we needed to list those out here because it's the absence of those that could be protective. Now, how do we talk about suicide? How do we assess this? Because for a lot of people, it still is kind of a taboo topic, but we have to make sure that we assess it. So we have to remove that stigma and that taboo from talking about suicide. So how do we do that? Well, first of all, we just need to make sure that we are asking about suicidal ideation or SI every visit with every patient. Doesn't matter if that is something that they have never experienced before, doesn't matter if it's something that is a concern. Sometimes what I do with my patients is say, hey, all right, I'm doing my job questions. Have you been feeling this way since I last talked to you? Um, that type of thing. Um, because that's the problem is that we can't really predict if and or when a patient's going to attempt suicide or if they're going to be successful when they do attempt it. So some of the things that we really want to make sure that we go even more in depth with our asking about suicidal ideation is our younger age folks. People pretty much below the age of, we'll say late 20s, still maintain a lot of impulsivity and reactivity to environmental situations and stressors. So that impulsivity in and of itself within that age group does place those folks at a higher risk. So again, we definitely want to ask about it. We want to make sure that we've got some safety plans in place. We've got, all of those types of things for that impulsivity age. And then, of course, also a lot of our patients, as well as everybody else who is alive, we do experience acute life stressors. Sometimes these are worse than others. Well, a lot of times with our patients, they might not be as well equipped as the next person to handle those stressors. So again, that's why we just want to ask about suicidal ideation every single visit with every single patient. Um, the biggest thing in just our approach to asking, you know, we can say the vague, non-judgmental, and empathetic approach, but the real thing is not to be uncomfortable talking about it. If you're uncomfortable talking about suicide and suicidal ideation, then your patients are going to be uncomfortable talking about it. So we set the tone as providers. Um, the whole point of asking about suicide, um, specifically during our initial interviews, is to assess that immediate risk for any kind of attempt. And we're going to do that by evaluating those current and past suicidal behaviors and suicide attempts, suicidal ideation, all of that. So that's our goal is we're assessing the risk. We're assessing the immediate risk. Also, knowing about current and past suicidal ideation can be a huge factor in our diagnostic decisions. Here's our list of some of the suicide assessment tools and scales. Take a look at those. I think the only one that I actually was able to provide for you guys was the Columbia Suicide Severity Rating Scale. Um, but maybe by the time you view this, those other two will be up there. And here's some other just evaluation questions. Um, and these are actually pretty good to just kind of quickly and easily make some fast evaluations of suicidal ideation and the risk there. There's a couple of things that I want to expand on with this one on sad persons. Um, when we talk about an organized plan, the reason that we want to ask about that, and it's not just, well, if you were going to kill yourself, how would you do it? We could all probably come up with a way that we would do it if we were going to. That is a horrible question to ask. What we want to ask is, do you have a plan? Not if you were going to. No, do you have a plan? Now we're going to hear a whole range of answers to that, but the thing that we want to be paying attention to is how detailed is that plan? Because the more organized, more detailed a plan is, the higher the risk because they've been thinking about it. They've been planning it out. When we say no spouse on this one, that just means anybody that's divorced, separated, or widowed. That does not necessarily apply to people who have never been married, but if they have been in a long-term committed relationship, then it would kind of be at the same level. And then when we talk about sickness, that's talking about chronic conditions and illnesses. So another part of suicidal ideation is the experience of what's called better off dead thoughts. Now, this is where we have to be able to view suicidality more on a continuum rather than a black or white, it's there or it's not type of situation. Because people who are experiencing better off dead thoughts, which would be kind of those first two, number one and number two, um, I wish I wasn't alive, I wish I was dead. Um, and if we allow them to finish out those statements, it's usually something like, so I don't have to deal with this anymore, so I don't have to feel this way. However, if whatever it is that's going on that is causing the better off dead thoughts isn't self-regulating, if it worsens, if it's something that is completely out of their control, then we could see these better off dead thoughts actually transition into full suicidal ideation. Suicidal ideation kind of begins with the statements of, I want to die. Now, there is a big difference between, I wish I was dead, to, I want to die, or I want to be dead. Okay? Huge difference there. So that's a big jump. And then of course we get all the way down to, we're at a 10, high risk, I want to die, I have a plan, and I'm going to do it. And I'm not going to tell anybody when. That's usually what happens. Now, when we're assessing our suicide risk, this is kind of the best approach, and is kind of recognized as the best approach for this type of assessment. And it's the CASE approach. It's the chronological assessment of suicide events, or suicidal events rather. And this is the order that we kind of go through it. Now, granted, you can certainly assess these in any order, but it flows quite a bit better if we go current, over the last 2 months, anything prior to that, and then return back to the present. Um, and that's when we're going to start looking for those protective factors. Um, this also kind of allows us a, a specific topic that can help us to establish rapport with patients, because it's the exploring the present and then going to the past and then coming back to the present again. That's kind of like, oh, okay, now I can kind of understand your situation. Let me uh, interact with you now that I understand you. Obviously, we won't say those things, but that's essentially what's going on there. This is just some resources. So write these down, print this slide off, whatever you need to do, um, so that you can offer these emergency services and just basic resources to your patients whenever they may need it. So let's talk about safety planning. So here's one of the big things with contracting for safety. Working in mental health, that is something that is very common to do in inpatient settings. Is just assessing the ability for contracting for safety. We also do it in our outpatient appointments as well, um, and that can look very different for a lot of different reasons. Um, but one of the things that we want to keep in mind when we are assessing this ability to contract for safety um, is the rapport that we have with that patient. Um, there's not a whole lot of credence that can be given to a patient contracting for safety if this is the first time that you've talked to them. Because what we're asking them is that from now until the next time that we see them, that they will not do anything to harm themselves. And that if they do feel like harming themselves, that they are going to let us or another identified support person know, and that they are going to follow direction to keep themselves safe. Um, if a patient doesn't have any relationship with you, it's going to be very easy for them to be like, yeah, sure, whatever. Right? So that's why when we're doing safety planning, it does actually need to be with someone that they have a established therapeutic and trusting relationship with. Um, Another thing that we're going to do with safety planning, though, is that we're going to also assess their home environment. Now, we might not be able to do that physically and actually go and witness and look at their house. But we can ask about things like, can we lock up knives? Are there any guns in the home? What about hazardous chemicals? Things like that. Now, thrown in treatment with this PowerPoint for this course, simply because we're not really going to come back in 543 to specifically talk about treatment of suicidal ideation. Because it kind of goes along with all of our other things we're going to be talking about. So, um, all antidepressants, of course, we have to remember this. All antidepressants do have that black box warning for increased suicidality. Now, there are some articles I gave you on that. Um, there's uh, there's also a lot of discussion about um, the fact that it might not actually be the medication itself for a lot of cases where um, kids, adolescents, and then into um, those early 20s, early to mid 20s, that it doesn't actually increase, or they don't actually increase suicidal ideation, but it's rather the impulsivity of um, that that age group. But again, doesn't really matter one way or the other, because if it happens, it happens, and we need to be aware of that. And recognize that it can definitely happen. Um, Most of the time, we're going to use antidepressants, but then also lithium. Lithium being one of the only medications that has actually been, you know, evidenced to decrease suicidal ideation. Um, and then doing therapy. That's one of the big ones. You know, it doesn't matter what medications we use. If someone is experiencing suicidal ideation, there is something big going on in their life that they are feeling it is better for them to not be alive, and they are willing to make that happen, or potentially make that happen to stop whatever it is that they're experiencing. Um, we can't fix that with meds. That's something that has to be addressed in therapy. And two of the things that therapy can bring specifically for suicidal ideation is that installation of hope, and then also to just increase those help-seeking behaviors. Um, and those are very important. When we do talk about major depression uh, treatment, there's actually some evidence that therapy might be more effective than antidepressants when we treat depression and suicidal ideation in kids. So just something, little nugget for the future there. Now, let's say that someone is experiencing suicidal ideation. They are, and they're not sure about anything at the time, right? So we have got a couple of different levels of care to choose from. One, we could try to schedule them an emergency appointment with us. Simply getting into one of their, mental health providers. If it's not us, then maybe a therapist. Within 24 hours, sooner if possible, same day, can greatly decrease the risk. I've for sure experienced that with my patients, where just after a brief 20 to 30 minute um, conversation, at the end of it, they're like, okay, I think I'm going to be all right now. Thank you. Talked me off the ledge. And that's a pretty frequent thing for our patients to feel that relief. Um, we want to see about safety at home. Can they be safe at home? Do they live alone? Do they live with someone that's trusted? How how would it be managed at home if they were to experience continued suicidal ideation? And so we want to kind of assess that and make sure that we do have a safety person at home, and that that person is also aware that they need to be keeping an eye on our patient. That's kind of a big one. And then, of course, we've got our crisis stabilization units, which are those voluntary, on average 3-day, 72-hour stays, um, or our inpatient psychiatric admissions. Now, I would definitely not recommend seeking inpatient admission for suicidal ideation um, unless there is nothing else available. If the CSU is full, and this person lives alone and they just do not trust themselves, or just flat out can't contract with an with a trusted provider, then at that point we're definitely going to want to seek inpatient admission. So to wrap up this lecture, let's talk about some of those myths about suicide. One of the big ones, I think, is that there's this idea out there that talking about suicide is going to increase that risk, and will um, change someone's mind into taking action. That is absolutely not true. There's literally nothing, there's no support of that. We're not going to put the idea of suicide into someone's head simply by asking about it, or talking about safety or anything like that. So If you ever encounter anyone that says anything like that, definitely set that record straight. Next one is there are talkers and doers. Um, there is this idea that people who talk about suicide and their desire to die um, are just that. They're just talking. And that those who really intend to attempt are not going to talk about it. They're the doers. The reality here is that we can't tell one way or the other. We do have some folks that, in a roundabout way, this might be kind of true, where we do have some people that will talk about it but would never do it. And there is some support for when people are at the end and they're ready to do it. They've got a plan. They're going to do it. They won't say anything simply because they don't want someone to interfere with their plans. Now, that does not mean that that is generalizable to the entire population. If someone is talking about it, we need to take that seriously. If someone isn't talking about it, we need to ask about it. There's the talkers and doers thing is not, that's not true. Um, you can't stop someone if they really want to die. There's so many parts to this one. Um, yes, we can. If we couldn't, then what are we doing? Um, the reality is that um, with the right interventions, with the right support, with the right person, right provider, we can actually change someone's mind. We can help them see that there are things to live for, um, that they decide that they don't actually want to. Um, so that one's definitely a myth. Then they're signing the that no harm contract. Now that's what I was talking about earlier with the contracting for safety. Um, and it kind of goes, they go hand in hand because sometimes some facilities actually will have an actual no harm contract that some, that patients sign rather than giving a verbal contract for safety. Um, and for some reason, there's this idea that if they sign it, that means that it's more powerful for some strange reason. Um, the power itself, again, comes from the relationship, the alliance, the therapeutic rapport that is between the patient and the provider. That is what gives contracting for safety and even signing a no harm contract strength. Um, so, and then finally, the idea of multiple self-interest behaviors. This, I kind of touched on this earlier as well. Um, when we have, like with our borderline personality folks, um, we do have a high likelihood of self-harming behaviors that are non-suicidal self-harming behaviors. That doesn't mean that they're not suicidal if they say that they're suicidal. Um, there is a big difference between non-suicidal self-injurious behavior and suicidal ideation and or attempts and or making plans. Um, even those folks that are engaging in that non-suicidal self-injurious behavior or self-harm, um, that doesn't mean that they're not at risk for suicidal ideation and attempts. Um, anytime someone is engaging in self-harming behaviors, um, we do need to assess the severity and the level of their suicidal ideation. Sometimes it's, something that they've just kind of developed over the years as a coping skill, coping mechanism. Um, Not an ideal one by any means at all, but I've had quite a few patients, you know, talk about that is something that they do to calm themselves, to keep themselves from escalating into suicidal ideation. But that's not going to be every patient. Um, and so again, we just have to pay attention and recognize that there's a difference, but it can escalate, um, and not to ignore it, which we shouldn't anyway. And that's all I've got to say about suicide. So, as always, if you guys have any questions or need any clarification, let me know.